My name is Paul Pockrass. I'm the director of the Liver Disease Center at Scripps Clinic in La Jolla, California, right up the road from here. I'm also the director of the Scripps Translational Science Institute in clinical research. So I have a fair amount of experience with hepatitis C. I'm going to talk to you today about optimizing hepatitis C management within a system of care using PCMH model to improve screening, treatment, and outcomes. So these are my faculty disclosures to begin with. These are our learning objectives. Simple, describe the growing epidemic of hepatitis C and what's changed over the last 25 years, how to implement appropriate HCV screening, and then to outline what we've done with therapy now. So first, let's describe the growing HCV epidemic in terms of shifting demographics under diagnosis and under treatment. So if you look worldwide, there are 70 million people infected. In the United States, the incidence is less. It's about 1%. But there are certain populations, like the baby boom population, where the prevalence is higher. The prevalence is 1.8 to 3.4% in the baby boom population because they were infected many years ago and they're still out there. So these are the population born between 1945 and 65. But you'll notice there are some parts, like if you look in North Africa, the red area there is Egypt. There's a very high incidence and prevalence of hepatitis C in Egypt because of accidental infection in the 1950s and 60s of a large portion of the population. So up to 20-25% of the population in Egypt is HCV positive. Russia, Ukraine, etc., you can see those Central European countries also have a very high prevalence. If you look at the countries with that account for 80% of the infections, they are listed there: China, Pakistan, India, Egypt, Russia, U.S., Nigeria. So the U.S. is in that top portion. Now, there are different genotypes of the virus. Just to remind you, if this is a review, I apologize, but genotype means there's at least a 30% difference in the nucleotide level and a 25 to 30% difference in the amino acid level, which represents long-standing diversity. This infection's been around for many, many centuries, and so it's evolved in different parts of the world, and therefore we have different types of virus that have evolved. The virus itself replicates very rapidly. Half-life of the virus is 45 minutes. The typical body infection is 10 to the 12th or 10 to the 13th virus. So that results in lots of very rapid viral replication and opportunity for lots of mistakes. The virus doesn't have a proofreading mechanism, so it makes mistakes. 1 in 10,000 viruses a mutation, so there's lots of genetic diversity and rapid dynamic changes of the virus. So if you look at an infected patient that has a normal viral load of 1 million, and they have 10 to the 12th virus on board. Most of that is wild type, but a small percentage are lots of small mutations. The most common genotype in the United States is genotype 1, and you can see from this older slide, half had high viral load, that's HVL, and about a quarter have low viral load. The other genotypes are primarily genotype 2, 3, and 4, 5, and 6 represent a very small portion of the U.S. population. Now, we haven't quite reached the peak of cirrhosis in the United States due to hepatitis C. We're probably about there. The advent of direct-acting antivirals, I think, has stopped the progression of disease. But keep in mind, my generation, born between 45 and 65, has had the infection now for 40 years. So most of the patients already have evolved and either developed cirrhosis. Many have died from liver disease or cirrhosis. How many of you know somebody or have had a patient that's died from hepatitis C-related liver disease or liver cancer. Yeah, it's not unusual at all. If you practice in a VA hospital, everybody would have raised their hand. So, but if you look at the epidemiology of the infection, it's changed. So in 2007, you can see it was all baby boomers, and the peak age was around 55. Now it's around 65 in the baby boom population, but you have a second group here, this second peak that's around age 25. And these are the PWIDs that are acquiring hepatitis C infection. So this has occurred in an unequal fashion throughout the United States. You can see the red states, there's been over a 200% increase in the number of young white adults that inject drugs that have developed hepatitis C. And the white states we don't have data for, but you can see California is in this high risk population. Lots of states in the Midwest and the South, etc. This has also led to mother-to-child transmission. So when you look at reproductive age women and their children, the incidence of hepatitis C is now increasing, not decreasing. And that's because of these PWIDs that are getting hepatitis C infection. Now, and by the way, this has had a tremendous impact on liver transplant centers. I work at a liver transplant center, our organ transplant centers, because we're getting large numbers of donors that are young IV drug users that OD, that have not died, that are brain dead, and that donate their organs, and many of them are HCV infected. So we're now we don't want to throw away those organs because they're precious. They need to be used. So we're using those for liver and kidney transplantation, even into patients that are not HCV positive to begin with, because we can now readily treat the organ. So if somebody gets an HCV positive organ and an HCV negative recipient, we can readily treat them with 8 weeks of antiviral therapy and prevent the hepatitis C infection in the recipient. So how well are we doing in practice? Well, to be honest, we really suck at this. We don't diagnose patients very well. We've only diagnosed about half the population that's infected. And if you look at those that then get diagnosed, their access to outpatient care is sometimes limited. And the number that have actually been treated and cured is relatively small. Now, this slide has got data all the way up to the end of 2014, and to be fair, since the beginning of 15, we've cured another 300 to 350,000 patients. So we've probably cured 600,000 or more patients with hepatitis C in the United States now, but there are still lots of patients that have not been treated and cured, and there are lots of patients that haven't been diagnosed. So why is this? Let's look at the hepatitis C screening practices. Well, this slide is very difficult to read, but I'll just tell you, this comes straight from the AASLD guideline document. That document is online. It gets updated every 3 months. It's 250 pages long, but you just go to it will list for you what you want to know. So if you want to say who gets screened for hepatitis C, it'll tell you simply, and it'll give you the rating category. So category 1B, very high rating, is one-time HCV testing for anybody born between 45 and 65. That's the baby boom population. And then the other populations that are at risk. These are IV drug users, intranasal illicit drug use because of blood-to-blood transmission. So somebody uses an intranasal drug, they bleed, and can share that blood with someone else who's doing the same thing. Long-term dialysis patients, so these patients are exposed to lots of needles in healthcare, and they are at risk for hepatitis C. Patients with exposures to lots of needle using one way or another. Healthcare providers, in the case of emergency or accidental needle sticks. That's done routinely. Children born to HCV-infected patients, prior recipients of infusion products before we had good screening. That was 1992. And persons who are incarcerated. So if you look at population incarcerated in the United States, how many people touch the penal system in the United States per year? Come on, you guys know come on, half you guys are on probation. Give me the answer to this question. You know the answer to this. 10 million. So that's a lot of folks. 4 million are in prison. But so the sad truth is, if you look at that population, the percentage that have hepatitis C when they go into or leave prison is very, very high. Highest among females, by the way, probably because of IV drug use. And the other things to consider are HIV infection, sexually active patients that have sexually transmitted diseases, and unexplained chronic elevations of ALT. Solid organ donors also get tested for hepatitis C. How do you do the testing? It's pretty simple. HCV antibody testing is cheap now. If it's done and you are positive, it should default automatically to an HCV RNA that's equivalent to a Western blot for HIV, and that confirms the infection. Patients that have liver disease also that may have had a recent infection should be tested for HCV RNA directly. So that's done in some cases also in immunocompromised patients where rarely they won't develop antibody. Now, people that get reinfected with hepatitis C have to be tested for hepatitis C RNA, not antibody. So once you're infected with hepatitis C, you have antibody for life. Antibody is not protective. So about 25% of patients that get infected spontaneously clear the infection, but they still have a positive antibody. So when you test that patient, they'll have a positive antibody, a negative HCV RNA, and normal liver tests. They do not have active hepatitis C. They don't have to be treated. If their RNA is positive, it should be quantitated, and that's typically how it's done. They should have a genotype, although most therapies now are pan-genotypic, so it doesn't matter. And you can tell people that they don't have an active infection if they're RNA negative. So this is sort of what the algorithm looks like. Antibody, non-reactive, you don't have hep C, you're done. If you're reactive and your HCV RNA is not detected, you don't have active infection, you're done. But if you've got positive RNA, then you have to quantitate it and refer the patient for therapy or link to care. So how well have we been doing with screening? So screening has been active. This program our initiative was started by the CDC in 2012. And it was simple. This advertising was all over the United States, and you may have seen it, a picture of Woodstock and Martin Luther King and the astronauts. All it's supposed to connect with the baby boom population and say, okay, dude, were you getting high during all this time, and were you using IV drugs or multiple sexual partners or whatever, and do you have hep C? And people are supposed to stop and go, gee, maybe I should get tested. So that was a good idea. They've had that out there 6 years. The recommendation was simple: get tested, and if you're identified that you have an HCV infection, give them a brief counseling about alcohol. So don't abuse alcohol. And unfortunately, for many years, we found lots of baby boomers that were drinking, probably excessively, but 30 grams in a male and 20 grams in a female. If you have hepatitis C infection, is not okay. So if I split a bottle of wine with my wife and one of us has hepatitis C, that's bad. It's going to lead to accelerated liver disease and cirrhosis. So and many patients were doing that, didn't know they had the hepatitis C infection, would show up with cirrhosis or liver cancer. And then the recommendation was get referred for therapy. So how have we done with that? Again, not very well. So Of the patients that are screened and found to have HCV antibody positivity, not everybody's HCV RNA tested, about 70% are. And of those that are tested, only about 75 to 80% are referred, and half of those don't show up for their appointment. So you lose patients along the way. So we are aware of at least 150,000 patients that have tested positive for HCV antibody and HCV RNA in different counties throughout the United States that have not been referred or have not shown up for their doctor's appointments. So, and that data has been collected by a nonprofit that's supported by pharmaceutical industry. Obviously, they have an interest to get all these people identified and treated. At least that's the low-hanging fruit. Those patients can at least be sent for a referral and get treated. So why aren't they treated? This is hard to read, but the contraindications to therapy that we used to think of, active substance abuse, psychiatric disorders, these are no longer contraindications. You're taking one pill once a day. Adherence is good. It's 8 weeks to therapy for 80% of patients. It's very doable, and there's data showing that active substance abusers and patients in opioid substitution programs do fine and have just as well SVR rates or cure rates. Competing priorities. So many of these people have chaotic lifestyles, disorganized lives, etc. They need somebody to guide them and say, get your hepatitis C infected. PWIDs particularly, there's a drive on to get them treated in order to reduce the risk of them transmitting. So PWIDs with a disorganized, chaotic lifestyle who are actively using her hepatitis C infection positive are dangerous. Treatment duration and adverse events, that's pretty much gone away. We don't use interferon anymore. Lack of access to treatment, that still remains, and I'll show you at the end briefly what the Medicaid expansions look like in different states in the United States. Where there's been Medicaid expansion, by and large, people can get treated regardless of their insurance status. And practitioner expertise has pretty much gone away. Now, DAA therapies, I'm going to just tell you what the goals of therapy are, what the two treatments are, and then I'm going to gloss over them. I'm not going to really talk about therapy in detail. I could talk, I go to meetings where we talk about treatments for the whole weekend, so it's really beyond the purposes of this. But just to tell you that there are many therapies now available that are very effective and well tolerated. That wasn't true for many years. So the goal of therapy is to reduce all-cause mortality and liver-related health adverse consequences. We've now demonstrated that in patients with advanced liver disease and cirrhosis. It'll take a little longer to demonstrate it in patients that don't have cirrhosis. To reduce the risk of liver cancer, we've demonstrated that. To reduce and to prove that sustained virologic response is durable, we've done that. Who should be treated? Anybody with a lifespan longer than 1 year. Period. So it's a lot simpler than the old days. I've treated a little old lady who's 92 years old because she got longevity in her family. She wasn't going to die from anything else. She didn't want to die from cirrhosis. And also, when she found that it increased her risk of stroke, cardiovascular disease, lots of extrahepatic things, she wanted therapy. So her biggest risk of dying is that she climbs up on a table to change light bulbs, that you can fall off the table. So for 20 years, we used interferon to treat hep C, and that was where the treatment got a bad rap because they had lots of side effects, difficult to take, and not effective in more than, say, a third of the patients. Starting in 2011, we had the addition of the first protease inhibitors. Then we went to interferon-free regimens, and then you can see all the drugs in development that occurred since then. We've ended up with the last two that I'm going to talk about. But essentially, we're at a point now where we can cure 98 to 99% of patients with 8 to 12 weeks of therapy that's well tolerated. The drugs we're using most commonly now are two. This one, which we call GP, or Mavyret is the brand name, I don't like to use brand names in a CME talk, but people otherwise don't know what you're talking about. But this is a combination regimen of a pan-genotypic protease inhibitor and an NS5A inhibitor. It's a pill you take. You have to take 3 pills all at the same time with food in the morning, but it's well tolerated. And this data basically, I'm not going to go over the details, but I'll tell you that overall SVR rate's 98%. 80% of patients can take 8 weeks in non-cirrhotic patients. So it's pretty simple. And there are certain rules about if patients have genotype 3, they're a little harder to treat. The PWIDs, by the way, that are developing acute hepatitis C are largely getting genotype 3. So that's a new epidemic of hepatitis C. Genotype 1 is the most prevalent in the United States, but the new infections are genotype 3. They're a little tougher to treat. We can also treat post-liver transplant patients now. We can treat patients with renal impairment on dialysis. We can treat, as I said, substance-abusing patients, et cetera, and even patients who have failed prior regimens. This is just to show you the adverse events from a real-life experience with GP that was just presented at a large meeting. It's like 700 patients, and you can see adverse events leading to discontinuation 0.2%, so 1 patient out of 700. So really, we've cured and treated over 1,000 patients at Scripps in real life and 250 in clinical trials. Most of them with soft-based regimens. Nobody stops because of adverse events, not like the old days. This is ledipasvir sofosbuvir, also known as Harvoni. You'll recognize that because that's the advertisements you see on TV. The overall cure rate, 96%. It's good for genotypes 1, 4, 5, and 6. And importantly, we can give it to patients with decompensated cirrhosis. So we have experience doing that. In the liver transplant centers, we've now listed lots of patients with hepatitis C and treated them while they're on the list. Their liver disease stabilizes and improves, and we take them off the transplant list. So there have been thousands of patients taken off the transplant list in the United States because of these therapies. The other drug is sofosbuvir velpatasvir. This is a pan-genotypic drug, very similar to Harvoni. And then lastly, there's this regimen, which is voxeloplivir, also known as Vosebi, which is a salvage regimen for anybody that doesn't respond. So the bottom line is we have therapies that are very effective. We also have real-life studies now from multiple different groups. These are not drug company groups. These are independent groups. The Target HCV Therapy group is one of them. It's academic centers. I'm in this one. And we've been collecting data for 6 years, looking at our real-world experience and showing that it's just as good as the clinical trials. The VA has data showing that. There's also real-life data collected from specialty pharmacies. So the therapies in real life are effective. This is what's happened. So when you look at the liver transplant waiting list, it's remarkable. In the last 4 years, the patients listed for decompensated cirrhosis due to hepatitis C has dropped dramatically. It's plummeting. You can see that on the red line there. The patients being listed for NASH cirrhosis is increasing. So NASH is now an epidemic in the United States. And the figures below show the prevalence of hepatitis B, and that hasn't really changed. Now, the incidence of liver cancer from hepatitis C is plateauing, but has not gone away. So we still see lots of liver cancers that require liver transplant. But the number of new patients needing liver transplant has really disappeared. Now, lastly, the access to therapy in California, we do pretty well. So they've just lowered the barrier to F1 fibrosis, so you can assess fibrosis by a non-invasive marker or a FibroScan. You don't have to do liver biopsy anymore. And with the Medicaid expansion, we can treat almost everybody that has hepatitis C. There are still states like Texas, Illinois, et cetera, where they're looking at F3, so they have to have more advanced liver disease or cirrhosis. So there are still some states where there's barriers to expansion. And there's also states where they do lots of drug and alcohol testing in order to determine if you're a candidate for therapy. That's left over from the interferon era, where we needed to know, because you couldn't make it through 12 months of interferon if you were using IV drugs or drinking. But there's clear data now showing that those are not really apropos. And, if you can have, some states say, well, you have to abstain for at least 1 month. That's reasonable. But to be honest with you, social alcohol doesn't affect the outcome of therapy. So in conclusion, the hepatitis C epidemic has changed in terms of shifting dynamics and demographics. We still underdiagnose and undertreat patients. Practices for at-risk patients have been available for the last 6 years. We're not very good at doing them, though. There are lots of barriers that prevent screening. Therapies, I think, are no longer a problem. We have pan-genotypic, all oral therapies that promote adherence, and they're very easy to give and work. And the clinical benefit has already been recognized in cirrhotic patients. We still are struggling with reduced treatment in many states that have limited access due to fibrosis and drug alcohol abstinence rules. Thank you very much.
Thank you. We'll be taking some questions after a few more slides to talk about how the information that you've just been provided will impact your implementation of criteria for the patient-centered medical home. For those of you I haven't met, I'm Mina Harkins. I've been with the PCMH program at NCQA since its beginning in 2008. And so we have always had in mind that chronic disease can be well managed within the patient-centered medical home. And we do need to look at the various workflows that you need to have in place in order to do this successfully. So we'll look at how you're going to bring this clinical evidence to individuals and coordinate their screening, their diagnosis, their treatment, and follow-up care. Whether you're in primary care or specialty care, there needs to be a working relationship between the two to really coordinate the care of these patients. So we'll talk a little bit about how this fits with the PCMH transformation, how it fits into those practices that are doing annual reporting, and how it would fit with the patient-centered specialty practices that you might be working with. So let's take a look first at how you're going to find these patients. Obviously, you need to be collecting data on the patient. You need to know about their social determinants of health. What's their medical and mental health history? Do they have some history of substance abuse? Simply their age, obviously, we're collecting that information. But there are a lot of other aspects of those patients and their history and their family and their environment and their past that are going to lead you to identify whether they're good candidates. So then we get to the opportunity to do outreach. How many of you are working with practices or in a practice that are actually reaching out to patients to offer them screening for hepatitis C? Not very many. My internist, I just noticed the result coming back. I didn't even pay attention to what was being ordered. Every 6 months I go in and get checked, and came back a result, for my hepatitis C screening. I said, oh, good, they're doing it. But they hadn't taken the opportunity to, tell me that it was a good idea. I'm glad he did it, but I think we're missing an opportunity there because, I have friends similar ages. I was one of those born between 45 and 65. And so, it's the kind of thing that is, people talk about their care and this and that, that we can, socially with our own circle, share the information that they ought to have about being screened. But as a primary care practice, you really have an opportunity to do this. It's a pretty simple outreach. You know their age, maybe getting to the patients who are PWIDs that are a little bit different, a little more sensitive about reaching out to them to be tested. But if you're collecting that information about, what their substance abuse or substance use experience has been, you might be able to identify them and, of course, then add it to the things that you're going to be testing them for. What are the other things that you can implement within your patient-centered medical home on the primary care side? Obviously, educational resources and self-management tools. The discussion around, are they also having alcohol abuse or, other things that might impact whether they could successfully be treated. So providing patients with information and where they can get information and what community resources are out there are obviously things that fit very well within the patient-centered medical home model of care. And you've got to order some lab tests. You need to be tracking them. Did they show up to get the blood drawn? If they've come into the office afterwards and didn't have that done, you have an opportunity to kind of follow up, stress the importance, do some education around the idea that, there are very treatable paths to take if they get a positive response. And so, sharing with them the evidence-based guidelines that are already well developed and the evidence is there that can be treated. So, whether they understand in the beginning about, what is available, just kind of getting them started by getting those tests done. And then as those patients coming in, as I said, be prepared for those that maybe, you've got the results, you're going to have a discussion with them, you're going to be referring them, or, you just are beginning that educational cycle, planning with the patients who are coming in, knowing, whether they've had the screening or not, helps you make good use of the appointments for those patients as they come into the office. The problem I think we find with a lot of those younger patients is they don't come into the office. So, we might need to expand around the opportunities to get those patients in. If they are employed and they do have health benefits, they have insurance, there's an opportunity there to, let them, to bring them into the office. So if they don't, self-select to make an appointment to come in for any kind of care, if they are covered under your plan and you're getting those lists of patients that are supposed to be attributed to your providers, you do still have the opportunity to reach out to them. So using those evidence-based guidelines, the physicians have certainly the opportunity to get this information. You noted that there was, less problem with the lack of experience on physicians. So, if the physicians in the practice have the opportunity to get up to date for these regimens that are out there now, it's certainly something then that you can share with your patients that, you have the most current evidence-based guidelines and up-to-date decision support. This might be more on the specialist side, but helping patients understand medications that they're going to be having. Maybe they do have some kinds of other problems going on that needs to be coordinated with their care, perhaps by the specialist. So, it gives the practice the opportunity to even for the primary care and the specialist to discuss the patient. Perhaps they need some co-management, other aspects of care coordination, making sure the patient went to their referral. I think on one of the slides it showed some of the patients while they got tested, confirmed that they're a candidate for treatment, got a referral to the specialist, but they didn't show up. Another opportunity for follow-up and outreach to better coordinate that care. Also, collecting information on the specialist. Do you have a good relationship or an agreement with the specialty practice that you're referring these patients to for their treatment of the hepatitis C? And then doing some testing or doing some measurement around, how successful are you being? Are you getting to screen those patients that should be screened? So the data that you're collecting for those comprehensive health assessments and clinical information, and then use that information to, look at how you're doing over time. Are you screening the patients? Are they getting their referrals? So several areas of quality measurement that you can find opportunities for your care for those patients. So looking, once you've established those measures, using it perhaps even as a quality improvement activity to, do even more outreach or do more follow-up so that you can see how you're doing over a longitudinal period of time. And if you're achieving performance, as you're going through maybe a PCMH transformation, gives you the opportunity for some additional credit there for achieving improvement. Some of those same improvements and activities can be used in your annual reporting. If you've already achieved recognition, how does this fit with you? Well, for us, annual reporting was always supposed to reflect that you're going to continue to improve. If you're doing well in some aspect of care, say you've got a great diabetes program, and you do very well with those patients, well, maybe these are patients that you should start focusing on for proactive reminders or their care management or co-management and referral tracking. So always opportunities to bring in new areas for your practice to develop better quality tracking and quality measurement. And then lastly, for those who work with patient-centered specialty practices or those that are specialty practices, whether you're a liver center or multi-specialty and taking care of these patients, looking at the handoffs between, do you have a good understanding of perhaps the testing that should be done before the patient is referred there? Do the specialists know, what records you've got available that you'll be sending with the patient? So coordinating so that, you don't have to repeat things and increase costs because you understand which of the providers is going to take care of which aspect of care. Keeping that information, providing timely response back, and, just helping the patients make sure that they get the self-care support, any resources out that is available to them out in the community. So those are just the things that I could identify that help the patient-centered medical home provide good quality care for their patients that may be candidates for this kind of care. So I think we have a few minutes if you have some questions for either of us, and then we'll go on to the post-activity survey. Any questions?
So the question is about the cost. It's a good question because sofosbuvir got the Sovaldi got the bad rap and lots of press about being the $100,000 therapy and $1,000 vape pill and blah, 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 blah. So the estimated cost now of those two standard of care therapies that I showed you for a cure is about $20,000 to $25,000. For the VA, it's under $10,000. So a cure is under, and that's not cost effective, that's cost saving. So it's beyond cost effective. When you look at the cost of a cirrhotic patient with hepatitis-c, it's very, very, very high for hospitalization. So very cost effective now. Costs went way down. The rest of the world can treat now for pennies, basically. So the question is, can you treat in the primary care office? Yes, we've talked about this a lot. So the only issue is that you have to assess fibrosis, and I didn't go into that, but you have to make one assessment of fibrosis, and it's no longer requires liver biopsy, so you can do it by so FQHCs are doing this in San Diego. Chris Raymer's group is doing this big time, and they're all over the country. I just came from a meeting in Chicago yesterday where we had a big discussion about this. So FQHCs are doing this all over the place. It's one pill once a day, and adherence is excellent. And adherence in the IV as these guys who treat PWID said, the adherence in the PWID group is even better because they know what adherence means and to miss a drug. But so very doable. But you have to have primary care physicians that are interested in doing it. There was a question over there. Yes. So the question is about the rapid hep C test. So there's now a point of care hepatitis-c RNA test that can determine a quantitative or qualitative, actually, a positive HCV RNA in an hour. And it doesn't require refrigeration. So that test was designed primarily for the rest of the world because the intent in the highest incidence countries is to test and treat on site. So you can do that with a point-of-care HCV RNA test. You don't need a quantitative level. You just need a qual. You're positive. You get treated. And they're giving them very inexpensive oral therapies that they'll start right away. They provide drug. It can be done in the United States. Hasn't caught, to be honest, 80-90% of doctors use Central Labs, Quest, and LabCorp, and those are HCV RNA PCR assays that are done in central laboratories. So the point-of-care testing has not really caught on as much, but it could be done.
And they don't need any other screening type test?
Well, they do. So, ideally, so if you're using a pan-genotypic regimen, you could argue you don't need genotype, but you do have to assess fibrosis somehow. So you have to decide who's got advanced fibrosis or cirrhosis, because those patients get followed differently. They have to have endoscopy for varices, they have to be screened for liver cancer, and then they have to be monitored indefinitely after cure for the prevalence of liver cancer. So you got that group, and they also get a different duration of some of the therapies. So if they're getting Epclusa, for instance, everybody gets 12 weeks, but if they're getting Mavyret, the ones with cirrhosis get 12 weeks, the ones without it get 8 weeks. So you have to make that differentiation somehow. That can be done with a non-invasive lab test in many settings. Yes?
So I had the luxury once of working with a primary care physician who also specialized in infectious disease, which as a nurse care manager meant that we were doing a lot of Harvoni treatments and things like that. So I would often call for the PAs for those medications for the patients. But with the genotype 3, what is the drug of choice?
So for genotype 3, Harvoni is not approved. LDV soft, ledapasvir, sofosbuvir is not approved. Sofosbuvir velpatasvir, which is the newer drug, Epclusa, is approved for genotype 3, and Mavyret's approved for genotype 3. So those are our two go-to drugs, and which one you use just depends on different factors, whether they have cirrhosis or whether they've been treated before or one thing or another. And often it's the payer. The payer will decide for you. And there was one other question, yes. Yeah. So the question is, so you got two groups of patients. The older patients that are the baby boomers aren't getting reinfected, but the PWIDs, the young people that are using IV drugs, are getting reinfected, and even after they've been cured. And some of the big centers in inner city, like Johns Hopkins in Baltimore, has lots of data on recurrent infections in inner city IV drug users, et cetera, and what the genotypes are and the variability. Interestingly, it appears though the patients are developing, the clinical illness is delayed after infection, after each new infection, and it appears that it attenuates and goes away eventually. So it may be that they're developing some form of protection. But so this has been an argument by many states that, okay, we're not going to treat you because we're not going to spend $20,000 to cure you because you're going to go out and use IV drugs again, get infected. But John Ward, who's in charge of the viral hepatitis branch of the CDC, says that it's herd immunity that is the key. And if they can reduce the number of active IV drug users, prevalence of HCV by 20%, they'll stop transmitting. And so the whole reason to treat them is so they don't give it to someone else. Yes. So screening for B in pregnant women, of course, is state law in California and third trimester, but it's not for hepatitis C testing. So most women don't get hepatitis C testing unless they ask for it. They're not in the baby boom population. But because of that PWID data and that rising incidence, it's a great concern. So, but it has not been added to the routine screening. Great. Everybody's happy. Thank you very much.
Perfect timing. Thank you,